So dear friends, now in this PPT, we will spend some time with understanding what is an intraocular lens, how this intraocular lens is designed and what are the parts of it and how it is used in cataract surgery and subsequent to a cataract surgery in the postoperative examination of the patient, what are the main points that are looked for and what are the telltale signs of having an issue and which needs to be addressed. These things we will try to cover in this PPT. Intraocular lenses were first invented by Harold Ridley. Harold Ridley is to be remembered because he's a ophthalmologist in the Royal Air Force, and the Royal Air Force during the Second World War had lot of patients, a lot of fighter pilots who came with injuries in their eye, and most of them it was shrapnel injuries where foreign bodies have gone and lodged into, especially the windshield of their helicopters, where the bullets pierced through the windshield and hit and shattered that windshield pieces, and they came and resided in the eye of these patients. They were observed by Harold Ridley and found to have not much reaction to the eye. He didn't need to remove it. It was just staying quiet without any inflammation. And that gave him the idea, why not use that material, which is PMMA. The material which he used here is called PMMA. And that PMMA material was considered to be a choice for intraocular lenses by Harold Ridley after having this experience of seeing the Royal Air Force pilots having injuries with PMMA, which is an original military research product used for the windshield of the helicopters. This is called polymethyl methacrylate. With polymethyl methacrylate, we make an optic. And there are dialing holes in the optic. Can you see the dialing holes? The dialing holes in the optic. And there is an haptic, or rather two haptics, in fact. Two haptics. These haptics go and hitch in the equator of the capsule, and this optic should be in the perfect pupillary axis, in alignment with the pupil, so that the patient has good vision. Any distortion or any eccentric placement of the lens will not give you good vision. In fact, you will hear about sunset sign, sunrise sign, windshield wiper sign. These kind of eccentric positioning of the IOLs is not good. We will see them again. And if it is perfectly aligned, intraocular lenses really give very good vision. And these are called rigid lenses, and they are made of PMMA. And this PMMA rigid lenses are mainly used in SICS surgery. So in SICS surgery, the main lenses used are these PMMA rigid lenses. Certain times, but there is a prerequisite for these PMMA lenses, that posterior chamber. These are called the posterior chamber lenses. Okay, posterior chamber lenses, posterior chamber intraocular lenses. So this posterior chamber intraocular lenses needs the posterior capsule to be intact to be implanted. If the posterior capsule ruptures, then this cannot be implanted. Then we have other options. What are the other options? The other option is to have a iris clip lens. This is called an iris clip lens. Iris clip. Can you see? This lens is kept in the pupil, and these two edges, these two haptic edges are stuck to the iris, and that is why it is called the iris clip lens. This is an anterior chamber lens. Can you see this kind of a funny haptic? The haptic which is like almost like a Z. Can you see an Z-like haptic? Here it is usually a C-type haptic, but here it is an Z-type haptic. And this Z-type haptic is seen in an anterior chamber intraocular lens. Anterior chamber intraocular lenses, this kind of iris clip lenses, and a special posterior chamber lens which has two eyelets here, which is used to suture to the sclera. This is called a scleral fixed lens, scleral fixation lens. So these are the three lenses which can be used in a patient whose posterior capsule is ruptured. So these are called, in fact, these are generally called secondary IOLs. Secondary IOLs are IOLs which are other than the posterior chamber IOLs, which are kept in an aphakic patient. In an aphakic patient who had the posterior capsule removed, then these are the options, the secondary IOLs. These secondary IOLs have their own intricate intricate points about each. And the most commonly questioned point about anterior chamber lens is, you please remember UGH syndrome. They will keep asking you about UGH syndrome. So remember that anterior chamber lens has two big problems. One is UGH syndrome, that is uveitis glaucoma ephema syndrome, and bullous keratopathy. So these are the two big disadvantages. Now we have exhausted PMMA options. Now we have foldable options, because we understood that these PMMA lenses need at least 6 millimeters to implant into the eye. But in a phacoemulsification, we know that we only create a 3 millimeter wound. So through a 3 millimeter wound, this lens will not go. The 6 millimeter rigid lens will not go. So we have to use a foldable lens. The foldable lens will be made of silicon and acrylic. Please remember, silicon is one and acrylic is another. These two materials are well suited for folding, and through an injector they can be implanted into the eye. So that is the story of rigid lenses, foldable lenses, and secondary intraocular lenses. Okay. Next, postoperative antibiotics. Postoperatively, we already discussed, we will have an antibiotic and steroid, certain times separately, certain times together, and they will start as 6 times in a day and slowly become 5 times, 4 times, 3 times, like that, and in 6 weeks it will get over. So the healing period is, don't remember 4 weeks, remember it as 6 weeks. 6 weeks is the healing period. So patient will also need to use a dark goggles, yes or no? Because the patient will have a glare, because he has just had a cataract surgery, his cataract lens has been removed, and intraocular lens has been placed. So in that initial transition period, he will have lot of glare. So to prevent the glare, we will use dark goggles for this patient. This patient will also be used mydriatic or a cycloplegic, and patient will also be used an artificial tear. And artificial tears will also be used. So these are the preparations which are used in a postoperative management of a patient. When will you give final spectacles? You will give final spectacles after the 6 weeks period. But in phacoemulsification, the healing time is half. Remember, phacoemulsification, the IOL size is also half. 6 millimeter IOL, rigid IOL becomes 3.3 millimeter foldable IOL, and the 6 millimeter healing period becomes 3 millimeters. 3 weeks, 6 weeks healing period becomes 3 weeks, and that is the advantage of phacoemulsification. During this postoperative management, what are the things you are going to look at? Ideally speaking, a cataractous person comes to you, you do a PACA examination, then do a cataract surgery, then you will have to have something like this. You'll have to have a clear conjunctiva. There should be no lid edema. There should be no wound congestion. There should be a perfect cornea, crystal clear cornea, a round pupil, and an IOL glare. Can you see an IOL glare? This is called a shimmering reflex or a glistening reflection of IOL, and these patients are called pseudophakic patients. If you have a normal lens in you, you are called a phakic patient. If you have an absent lens in you, then you are called an aphakic patient. If you have an artificial lens in you, you are called a pseudophakic patient. So this is the normal expectation in most of our patients. But incidentally, whether because of many factors, which can be patient factors, surgeon factors, the patient ends up with certain complications. One of that complication is these sutures. Can you see? They start with the SICS, but then they have to convert it into ECCE, and finally they have to finish the surgery and do sutures. That is one thing. That SICS, if it is completed by itself, then it will become a sealed wound because of the valve. But if it is converted to ECCE, then you'll have to suture that wound. Certain times a phacoemulsification will be started, then it will be slowly converted to an SICS because phaco cannot be continued with. Likewise, one surgical maneuver which is started with might be turned over to another maneuver, changed over to another maneuver as the situation demands in a particular patient. Next is, can you see the corneal edema? And can you see the corneal haze? This haze is called SK. This is called striate keratitis. This is called SK. This is a very common complication following cataract surgery. I am just trying to show you the images so that they fix in your mind. These images fix in your mind. And can you see this patient having some amount of haze over the IOL? Can you see that fibrinous material over the IOL? And can you see the hypopyon? Can you see that 1 millimeter hypopyon? Can you see that white hypopyon here settled down? And this is endophthalmitis. Here you can see nicely. Can you see this? The almost 1.5 millimeter to 2 millimeter hypopyon. Can you see this hypopyon is characteristic of endophthalmitis. Endophthalmitis is a dangerous complication. There are two feared complications. During surgery, expulsive hemorrhage, and after surgery in the postoperative period, endophthalmitis. So we will discuss them separately. Okay. So in this session, we try to look at intraocular lenses, the types, nature of intraocular lenses, their plus and minus, their sizes, and special situations. And then we went on to see what are the postoperative medications usually a patient will take, and in that postoperative medications, how long they should take, and what are the postoperative images which we need to fix in our mind to see a normal eye, an eye with minimal complications like SK, which we hope to resolve over a period of time, and severe complications like endophthalmitis, which needs to be interfered and managed with. Thank you.